The TB capital, accounting for almost 26% of global incidence, and RNTCP was revised in 2016 with daily ATT regime leading to making patients more prone for developing ethambutol optic neuropathy. Ethambutol is the first-line ATT drug with potential hepatic and ocular side effects. It acts as a chelating agent which disrupts one of the several metal-containing enzyme system leading to ethambutol neuropathy. It is dose and duration dependent, and its incidence widely varies from 1 to 18%. It is partially reversible in initial stages and become irreversible later on. Ethambutol toxicity typically presents between 3 to 5 months, and it presents as bilateral subacute painless loss of central vision, and the fading of colors is the earliest sign. In 13 to 15% cases, patients are asymptomatic but have subclinical toxicity as assessed on VEP and OCT. It is of two types, axial neuritis and periaxial. Axial neuritis is the most common type, leading to visual loss, color vision impairment, and the secocentral scotoma because it affects the papillomacular fibers. Fundus examination may be normal in initial stages, but later on it can become hyperemic, disc edema, disc pallor, and optic atrophy in the later stages. EON, our experience. Over a period of 1 year, 100 patients were referred from CTB department for ophthalmic evaluation. Only 18 patients were diagnosed with ethambutol optic neuropathy, out of which 12 were male and 6 were females, with a male to female ratio of 2:1. A prospective randomized comparative trial was conducted, and the age group was from 17 to 75 years. Incidence of EON was 18% in our study. The average dose of given ethambutol was 800 milligram per day, and the most common type of TB was pulmonary TB, followed by spinal and genital. The most common presenting feature of EON was bilateral diminution of vision, followed by abnormal color vision in 11% cases. 14 patients were having defective color vision in red-green spectrum. Fundus and disc abnormality was present in 70% cases. It was normal in 30% cases, hyperemic disc in 15%, temporal disc pallor in 30%, and 25% cases were already having optic atrophy. Variable fundus presentation in EON, as you can see, the first picture is the normal fundus picture. In the other, there is disc edema, hyperemic disc. The third picture, all these pictures are of one patient. Then the patient progressed to the temporal disc pallor and ultimately optic atrophy over a period of 2 years. Visual field analysis was done in every case, and the abnormality was seen in 50% cases. The most common abnormality was central or secocentral scotoma in 89% cases, while in one patient there was bitemporal visual field defects. 90% cases OCT changes were seen. Increased RNF and GCL thickness was seen in 17% cases. However, thinning was seen in 72% cases. These are the OCT picture. In first picture, there is hyperemic disc with disc edema, which is showing increased RNFL thickness, while in the second picture, it is temporal disc pallor leading to RNFL thinning. The factors which were positively correlated with EON was the duration and dose of ethambutol, advanced age, hypertension, chronic smoking, and the renal dysfunction. So we have given trial of levodopa in our patients, as there is no safe dose of ethambutol and no definitive treatment. Why we give levodopa? Because there is established role of levodopa in recent onset NAION. With this background, we conducted a trial of levodopa in established cases of EON after taking clearance from the Institutional Ethics Committee. Total 18 cases were included, which were divided equally into two groups, cases and controls. 100 milligram levodopa TDS for 6 weeks was given, along with the zinc and vitamin supplements after ruling out the contraindication. Outcome measures, primary outcome which were measured were the changes in BCVA and the visual field analysis at 6 months from baseline. Improvement in BCVA was defined as a difference of 0.3 logbar or more after 6 months, and the improvement in visual field analysis was defined as a difference in mean deviation of +3 decibel or more. So results at 6-month follow-up, as we can see, the mean baseline BCVA was normal in cases as well as controls. There was no difference. However, at 6-month follow-up, it was significantly better in the cases who were given levodopa. Visual field analysis, it was improved in 5 cases in group A, while in 4 cases in the group B. This is a diagram that is showing the difference in the baseline active BCVA in cases and controls. Comparative analysis of group A versus group B was done in terms of visual acuity, and we can see there is significant difference in the patients who were given levodopa. Discussion, as there is no safe dose for ethambutol and its toxicity is reported at a dose of even as low as 12.3 milligram per kg per day, the incidence is largely dose dependent, and as per new guidelines, average dose is 20 milligram per kg in adults, while in children it is 25 milligram per kg per day, which is significantly high. The risk increases in conditions like malnutrition, advanced age, alcohol, tobacco, renal dysfunction, diabetes, and hypertension. Till date, there is no definitive cure for ethambutol-induced ocular toxicity. Therefore, early diagnosis and timely intervention is the key to its management. It should be stopped immediately with the supplementation of zinc, copper, and vitamins, especially methylcobalamin and pyridoxine, and we can add levodopa after ruling out the contraindication of any monoamine oxidase inhibitor use. The main purpose is primary prevention, and the information material should be given to patient. All patients with high risk factor must undergo baseline ophthalmic evaluation before starting. Levodopa appears to be beneficial in treatment of ethambutol-induced optic neuropathy. However, large multicentric studies should be conducted to be more conclusive regarding its efficacy. Thank you.
Thank you, Dr. Monica. What was the reason for deciding on levodopa?
Sir, as there are many articles that are published over the use of the levodopa used in non-arteritic ischemic optic neuropathy, and there is no certain cure, so we wanted to evaluate the role of levodopa.
But how does it affect the pathophysiology of ethambutol toxicity?
Sir, we have stopped ethambutol and we are already following the primary treatment. Along with that, we have added the levodopa. We haven't stopped.
I wanted to ask, what is the scientific basis of adding levodopa to...
Sir, as it has a protective role in the RNFL thickness, and there are 2-3 articles that are already in phase 3.
In ethambutol toxic neuropathy?
No, sir. Yeah, sir. The patients who were given ethambutol, OCT changes were being studied, and the cases who were given levodopa, there is less decrease in the RNFL, even after UAL.
How was it justified? Because the background of ethambutol toxicity is zinc chelation and affecting the oxidative
Sir,
cycle.
as it is partially reversible in initial stages, and we wanted to increase the neurotransmitter level in these patients, and I think there is already a trial going on in AIMS also over this study.
No, I wanted to ask the justification. Whether it's going on in AIMS is not the justification. I wanted to ask that what is the scientific justification of giving levodopa to...
Sir, as the dopamine is a neurotransmitter, and that will help in the...
Okay, sure, great.
Thank you, sir.
Just wait, I think there are a couple of more questions.
You're Dr. Monica, isn't it?
Yes.
Yeah, just to confirm. Good presentation.
Thank you, sir.
I mean, timing for 5 minutes each talk? Each? Yes, yes. Thank you so much.
Thank
Thank you.
Shall I start, sir?
Dr. Mahima
Yes.
Kaushal, who would be presenting on effects of ethambutol on ocular structure and function in patients receiving ATT.
Good afternoon, everyone. I'm Dr. Mahima Kaushal from GMCH Chandigarh. I'll be presenting my paper, Effects of Ethambutol on the Ocular Structure and Function in Patients Receiving Anti-Tuberculous Therapy. Tuberculosis remains the leading infectious cause of death worldwide, and the drug-resistant strains remain a major concern. In response, India launched the National Strategic Plan for Tuberculosis Elimination. Ethambutol is one of the FDA first-line agents. However, one of its major drawbacks is its potential to cause irreversible ocular toxicity, the risk of which is dose and duration dependent. So the current study focuses on evaluating the changes in ocular structure and function in the TB patients undergoing the current treatment regimen, considering the increased risk with the current regimen. Moving on to methods, it was a prospective and observational study involving 110 patients who were diagnosed with primary TB and started on antituberculous therapy. They were evaluated at baseline, 2 months, and 4 months. The sample size calculation is as shown. All the enrolled patients received their medication from a single dot center, doing away with any manufacturer bias by ensuring that all the patients received the same potency drug. The exclusion criteria is as shown. For methods, we evaluated visual function by logMAR of best corrected visual acuity, color vision by Ishihara's, contrast sensitivity by space enrichment and online test, and Humphrey Visual Fields 30-2. For structure, we used OCT and visual evoked potential. Strict vigilance was maintained throughout the study. Patients were advised to follow up, to report back immediately in case they experienced any ocular symptoms. If ocular toxicity was found, then upon conjunction with the Department of Pulmonology, we pushed for ethambutol cessation and continued monitoring to look for reversibility. For statistical analysis, we used frequency distributions, means, and standard deviations. The baseline data was compared with that at 2 months, 4 months using a chi-square test, and a value of less than 0.05 p-value was considered statistically significant. For results, the basic demographics are as shown. The average age ranged from 18 to 64 years. The duration of treatment ranged from 5 to 12 months. The p-value of visual acuity and color vision did not prove to be statistically significant for our study. However, as early as 4 months, we noted that at least 4 patients experienced at least a 1-line decrease in the visual acuity by Snellen chart. At least 3 patients displayed disturbance in their color vision. The contrast sensitivity, total, and central spark scores also proved to be significant. The common visual field defects which we came across in the ethambutol induced ocular toxicity patients were peripheral construction in 7.2% of them, paracentral and central scotomas in 3.6% of them, and temporal field defects. The average OCT RNFL thickness showed a progressive decline. The same was noted for amplitude of visual evoked potentials. However, no change was noted in latency. Broadly, the cases which we came across were reversible and irreversible. A case of each category is shown. Such was the case of a 23-year-old female with pot spine who was fine until her 4th month of treatment when she started experiencing blurring of vision. All the parameters also showed decline, but the optic disc was relatively healthy. So immediately ethambutol was stopped, and gradually by the end of 1 year, she showed gradual improvement, and all the parameters also improved. The other group of patients were not so fortunate. Such was the case of a 27-year-old male with pulmonary TB, who after a period of missed follow-ups came back with severely diminished vision and optic disc pallor. And to this date, even after having stopped his ethambutol, satisfactory vision has not returned. In conclusion, this study highlighted the subclinical to clinical manifestations of ethambutol-induced ocular toxicity. Optic nerve atrophy definitely proved to be a poor prognosticating factor, and the drawbacks we came across was not being able to rule out the confounding toxicity offered by isoniazid, and the fact that it was a short follow-up study. Lastly, as a food for thought, might we ask ourselves, in a rush to meet the ambitious TB elimination targets, are we truly claiming victory if it comes at the cost of our patients' vision? Thank you.
Thank you, Dr. Mahima. You followed them up for 4 months or 1 year? You gave some results of 1 year.
Yes, sir. The treatment which they were kept on was for 1 month, but for our study, we collected data up till 4 months. If any patient was followed up to look for reversibility, like for example the representative cases which I displayed, then they were followed up continuously, even till now.
Okay. Were they, you couldn't pick up any difference in any of the baseline parameters between those that improved and those that did not?
Yes, sir. The factors which indicated that the patient would go into poor prognosis was increased age or having any coexisting comorbidity like diabetes or renal dysfunction.
So that was statistically different?
Yes, sir. Yes, sir. Although for the scope of this study and for the paper, I did not go into the depth of all.
Because that's a very, very important thing, because that's the most important learning we would have so that we can prognosticate. So maybe when you're publishing, you should keep that in mind, because like I said, that's the most important thing we would want to know as treating physicians.
Yes.
So as you said, did you try to divide them as reversible and irreversible, and try to compare the parameters, baseline parameters between the group?
Ma'am, not really. We only categorized and summarized all the patients who were showing actual toxicity and segregated them from the rest.
Okay, so what percent of your patients showed improvement?
Out of 110 patients, ma'am, 17 patients had shown
improvement.
That signs of toxicity.
Okay. Okay, okay. And you did not look at whether those who showed toxicity improved or not.
Yes, ma'am. I'm saying that for this study, for the paper, I did not segregate with how many were reversible or how many were irreversible.
Okay, thank you.
Thank you.
That is out of your scope of your study.
Yes.
You are a resident?
Yes, sir.
Is it
This was my
your
PG.
thesis?
Yes, sir.
Because
yes.
your exclusion criteria is a screenshot.
Yes, sir.
Okay, okay. All the best.
Thank you, sir.
Dr. Rohan, for his free paper, Functional and Psychological Impact of Ethambutol-Induced Toxic Optic Neuropathy.
A very good afternoon. Today I'll be presenting the paper titled Functional and Psychological Impact of Ethambutol-Induced Toxic Optic Neuropathy. So tuberculosis is a pandemic affecting around 10 million people annually, and ethambutol is a commonly used first-line anti-tubercular agent. However, it can cause dose-dependent optic nerve toxicity, which fortunately for most patients is recoverable. However, the psychological and functional impact of said toxicity has not been evaluated in detail. So for the purpose of the same, we conducted a prospective observational cross-sectional study over a period of 18 months after approval by the Institutional Ethics Committee. We studied patients newly diagnosed with ethambutol-induced toxic optic neuropathy based on specialist examination and aided by investigations as and where necessary. To exclude the effect of confounders, we excluded patients who had visually significant cataracts, corneal or macular pathologies, glaucoma, physical disabilities limiting day-to-day activity, neurological deficits, cardiorespiratory status affecting ambulation, or psychiatric disorders. So consenting patients who fulfill the study criteria were analyzed for age, sex, duration of anti-tubercular therapy, BCVA at presentation, time between initiation of ATT and onset of vision loss, time between vision loss and presentation for care, and psychofunctional assessment was done with the Indian Vision Function Questionnaire, which is a 33-point questionnaire and has questions graded on a Likert scale, in which higher score correlates to worse function and more distress. It is further subdivided into 3 subscales, being the general function or VFI-GF subscale, vision-related psychological distress subscale or the VFI-PV subscale, and the psychosocial distress or VFI-PG subscale. So we had a total of 20 patients who presented with bilateral asymmetric vision loss and were on ATT for about 7 months. The average duration of ATT before vision loss was 5.5 months, and the lag between vision loss and presentation to care was a month and a half. All of them had reasonable afflictions towards general function, vision-related psychological distress, as well as psychosocial distress. Worsening BCVA, whether it be mean BCVA or BCVA in the better eye or BCVA in the worse eye, correlated significantly with worsening of general function for all patients. Drop in BCVA to worse than 0.3 logMAR units causes significant drop in general function as well as vision-related psychological distress. So a longer duration of ATT before onset of vision loss correlated significantly with worse BCVA and therefore worse general function on presentation, and a longer duration of vision loss before presentation correlated with worse psychological distress, general social distress, and vision-related psychological distress on presentation. So ethambutol, as we know, causes a dose-dependent toxicity, with the risk of which increases with longer duration of treatment and dosages more than 15 mg per kg per day. And 50% of patients may have subclinical ethambutol-induced toxic optic neuropathy after 6 months of therapy, regardless of symptoms. The vision loss can handicap their general function and affect their mental health, resulting in worse health-related quality of life. Prolonged vision loss can worsen these effects further. It has been shown in earlier studies that patients may be willing to trade up to half of their remaining lifespans for regaining vision, so these things need to be taken seriously. So the mainstay of treatment is early diagnosis and cessation of ethambutol, following which patients may recover or have persistent low vision. If in case the vision does not improve for said patient, we can always have the option of going for low vision aids and thorough counseling. Awareness of low vision services to increase the uptake of the same, perceptual training and environmental modification can further help improve their quality of life. So to conclude, ethambutol-induced toxic optic neuropathy causes significant vision loss and psychofunctional disturbance. Worse BCVA causes worsening of general function. BCVA worse than 0.3 logMAR units causes significantly more psychological distress. Screening, early diagnosis and cessation of ethambutol are crucial. Counseling and low vision aids may be used for the treatment of patients on a case-by-case basis, and more effort may be laid towards patients with worse BCVA on presentation. Thank you.
Thank you, Dr. Rohan. You did not have any control group where you compared these scores?
No, sir.
The question why I asked this was that how are you labeling this as the quality of life affected because of ethambutol? It would be the same. I mean, why would the scores be different if the vision loss was due to some other cause?
So it could be, definitely could be. However, since we have excluded all other causes of vision loss in the patient.
No. I didn't mean that the vision loss in this patient is clearly ethambutol related. What I meant to say was that to say that this distress is related to ethambutol is not there. So, I mean, I would rather say that this is just a quality of life questionnaire which is showing distress in patients who have subnormal vision rather than ethambutol toxicity. You've clustered a group of patients who are ethambutol toxicity related vision loss. I can cluster a group of patients who were, post-tumor, whatever, pituitary macroadenoma vision loss, and the VFQ scores would have been similar. What I wanted to say was that if you had a comparison with some other acute or chronic disorder, maybe, you would have picked out something more that this is more specific for ethambutol as compared to, that was my question.
Exactly what I thought also. You could have taken overall diminution of vision as one side and only those because of ethambutol. Then you may have whether this is above the average or below the average, which rather than talking about the treatment aspects, that will be a better thing. Just a suggestion. Thank you.
Thank you, sir.
So these patients were this was vision loss was self-reported, and
Yes,
then
yes.
they presented to care on their own later, is it?
Yes, sir. All self-reported, sir.
So we don't know that they probably came to self-reporting only when it got severe already.
Yes, sir.
So I think that's another important factor to put in,
Yes, sir.
because self-reporting patients will always report later than if you pick it up subclinic.
Definitely, sir.
Thank you.
Thank you. Now may I request Dr. Jyoti Shivaran to present her paper on ganglion cell complex thickness as a structural biomarker for visual outcome in optic neuritis.
Good afternoon. Yes. Sir. I'm Major Jyoti. I'm presenting the paper, The Role of Ganglion Cell Layer in a Plexiform Layer Thickness as Structural Biomarker of Visual Outcome in Optic Neuritis. Optic neuritis is defined as inflammation of the optic nerve caused by damage to the protective myelin sheath which is surrounding the optic nerve with an idiopathic etiology. Mostly unilateral, presenting in the age group of 15 to 58 years, has shown female preponderance. Optic neuritis patients present with a triad of visual loss, pain on ocular movements, and dyschromatopsia. The diagnosis is usually clinical. However, certain investigations like VEP, OCT do provide us supportive evidence. Most research in these conditions have been focused on peripapillary retinal nerve fiber layer. However, recently some studies have suggested that ganglion cell layer and inner plexiform layer complex measurements at macula may be more accurate and reliable biomarker of the final visual outcome after an acute attack of optic neuritis. Macular IPL thickness demonstrates a more accurate relationship with visual acuity or visual field, as it is unaffected by acute optic disc edema, has no large vessels, is unaffected by refractive errors, and has less subject variability. Measurements can be taken immediately, whereas in RNFL, it takes more than a month for the edema to resolve. Although thinning of GCL IPL and nerve fiber layer follow the same trajectory, it has been seen that the nerve fiber layer thinning occurs later than the GCL IPL thinning, and mostly it occurs during the first 2 months. And considering the fact that macula contains approximately 50% of the retinal ganglion cells and optic neuritis tends to affect the central visual field, GCL IPL measurement might detect early structural loss. So the study was conducted. It was a prospective cohort study done over 18 months in 25 eyes. The age group was 18 to 50 years, presented with unilateral acute demyelinating optic neuritis. The exclusion criteria excluded myopia, hyperopias, extreme hyperopias, astigmatism, dense cataracts, patients with other causes of ganglion cell loss like optic nerve drusen, glaucomas, and other causes of optic neuropathy, bilateral optic neuritis, recurrent optic neuritis in the same eye as in case of multiple sclerosis. A detailed history was taken. The vision was recorded with Logmar visual acuity, refraction, slit lamp examination, the pupil size, intraocular pressures, then the complete fundus examination was done. Color vision was done using HARS and contrast sensitivity with Pelly-Robinson's chart. Flash VEP was done in all cases to aid diagnosis. SD-OCT was done. It was done using the scan 6 into 6 mm area at the macula. GCL IPL thickness measurement was done by taking the segmentation scan, and RNFL thickness was done using a ring scan. The analysis was done with 8 of the macular ET DRS sectors, excluding the central 1 mm of the image. After diagnosing, we started with the pulse steroid therapy of 100 mg dexamethasone over 1 to 2 hours for 3 days, followed by oral prednisolone 1 mg per kg for 11 days. The calculation was done using the student pair t-test. Binary logistic regression analysis was applied. The observations and the results: most patients were in the age group of 19 to 40 years in our study. The distribution was similar, in our study, it was similar in both sexes. More than half of the patients presented to the clinic within 3 days of onset of symptoms, whereas 76% presented on the day of 6th of onset of symptoms. The most common complaint was diminution of vision. Both visual acuity and the contrast sensitivity improved significantly after starting the pulse steroid therapy as measured on day 30 and day 120. We did the comparison with the other eye. The changes in the visual acuity in the optic neuritis patient. Significant improvement of visual acuity was seen from day 0 to day 30, and improvement between day 30 to day 120 was insignificant. The comparison between the contrast sensitivity between day 0 to 120, contrast sensitivity improved significantly from day 0 to day 30, and improvement between day 30 to day 120 was again insignificant. Significant thinning of GCL IPL layer was seen in the eyes with optic neuritis. When we compared it with the other fellow eye, the similar changes were seen, and the inter-eye differences increased from day 0 to day 30, and from day 30 to 120 was again insignificant. The correlation was drawn between GCL IPL thickness and visual acuity from day 0, 30, and 120, and a slightly positive correlation was observed between the visual acuity and the GCL IPL thickness. The GCL IPL thickness was also compared with the contrast sensitivity, and positive correlation between the GCL IPL thickness and contrast sensitivity was seen. So the discussion: the mean GCL IPL thickness showed a significant decline starting from the first visit up to the end of the observation period. The greatest change, however, was seen at the end of the first month since presentation. Presence of peripapillary axonal swelling makes the acquisition of maps difficult. This implies that the significance of using GCL IPL thickness map as an early biomarker for early axonal injury in cases of acute optic neuritis.
But I need to sum up quickly because you're over time already.
Sir.
Negative marks for over, right?
More is the GCL IPL thinning, more is the vision loss. Therefore, GCL IPL thickness monitoring will help. With the help of SD-OCT can be used as a biomarker for final visual outcome in patients of optic neuritis. Thank you.
You can ring the bell for the timer. Yeah, but it's going on in the corner. Yeah.
On the top.
That's what I told you, on the right
screen,
corner. Yeah.
Right. Any comments?
So are you saying that GCIPL can be a marker for acute optic neuropathy? When the optic neuritis is just happening.
Yes, sir. But we can monitor a patient. That is a more stronger marker to tell us how much is the visual outcome going to be end of the treatment for the patient.
So it's that's why the title was a little misleading, and I think that's what we were thinking about. So biomarker for prognosis. So won't use the word biomarker. It's a prognosticating investigation is essentially what you're trying to say, that the effect on the GCIPL can help us to prognosticate the final visual acuity of this episode of optic neuritis.
Yes, sir.
These were all multiple sclerosis, or
no, they were not multiple sclerosis. They were MS was ruled out to
So
include.
what was the cause of the optic neuritis in these cases?
So it was usually idiopathic, and we.
Like I said, what else have you ruled out? NMO MOG was done in these patients?
Yes, sir.
And they were all negative for NMO
All
MOG?
negative, sir. MS was ruled out in every patient.
I'm not actually so concerned about MS. I'm more concerned about NMO and MOG, particularly NMO, because NMO has been known to be very early affecting the GCIPL. So, that may be one of the confounders. If they're all NMO MOG negative, that's fair enough.
How do you say that's a good prognostic indicator? Did you correlate your final visual acuity with your initial GCL?
Yes,
thickness?
yes, ma'am, we did that.
So at the baseline, you did.
And at the presentation day, ma'am, and at day 30 and day 120, when we compared the results, it was that people who have present at day 1 and are started early on treatment, they have good results with the GCL IPL thickness, and it's a good prognostic marker that way.
Okay.
Right,
Right,
thank
so
you.
moving on, may I request Dr. Anita Kumari to present her paper on CSR as a cause of decreased vision in MOG optic neuritis. Dr. Anita is there? No?
No.
Okay. So we move on to the next one, Dr. Ashi Jain to present her paper, please. She's also not there. Okay. So Dr. Gazela is there?
We can ask again.
I think there's some collaboration. So we're moving to. Sorry?
Varsha Negi.
Dr. Varsha Negi, I'm sorry.
Yeah,
Dr. Varsha Negi, I'm sorry. She's the presenting author. So she'll be presenting on glial fibrillary acidic protein. All yours, please.
Good afternoon, everyone. I'll be presenting GFAP antibody-associated optic neuritis. It's not moved. So 25-year-old female presented to us with a history of seeing bright visual objects in both the visual fields since 4 months. In the last 2 months, she also gave history of blurring of vision with transient visual obscuration in right eye, which was gradually progressive, and there was also mild blurring of vision in the left eye. The complaints were not associated with any pain, fever, headache, any sensitivity to light, nausea or vomiting, no history of any muscle weakness, numbness, tingling, dizziness, and there was no history of any trauma. She initially presented some other eye clinic where she was referred as a case of idiopathic, she was diagnosed as a case of idiopathic intracranial hypertension and thereby referred to us. On further history taking, there was no history of any systemic illness, no history of any drug intake, no similar history in the family, and she was a mixed diet, no history of any smoking or alcohol, bowel bladder habits were absolutely normal. A patient was of average build with a BMI of 24.2 with the normal BP and pulse rate. On CNS examination, patient was conscious and well oriented to time, place, person. All the cranial nerve examination were normal except for the optic nerve. There were no presence of any involuntary movements. On eye examination, right eye had a best corrected visual acuity of 636. In the left eye, it was 6/6. The color vision in the right eye, the recognition slide was not red, and it was 20/20 in the left eye. Pupil in both the eye were, the iris pattern was radial both eyes, normal in color. The pupil had RAPD grade 1 in right eye, whereas normal pupil reflex in left eye. When the patient presented to us, this was the fundus examination. The right eye showed nasal margin mildly blurred. The cup disc appears to be 0.6:1 with more pallor as compared to cupping. And the left eye had disc margins blurred in all the quadrants with hyperemia. Pattern lines were seen in both the eyes. This is the fundus picture of that same patient 1 week back when she had presented to some other eye clinic. At that time also in the right eye there was nasal margin blurring, obscuration of vessels, and the left eye the entire disc was elevated and the vessels were obscured the disc margins. This is the OCT RNFL of the same picture, of the same patient. Right eye showed, left eye showed disc edema, and the left eye, in the right eye there was nasally slight elevation of the RNFL. The left eye, when we entered with the macular GCC, both the eyes had significant thinning in all the sectors. This is the previous RNFL OCT RNFL and GCC of the same patient, in which both the eyes had bilateral disc edema. And at that time, the macular GCs in the left eye were relatively better as compared to right eye. This is the visual field of the same patient. Right eye showed superior altitudinal defect, and left eye was within normal limits. So we entered with this blood investigations in which the CRP and the ESR were elevated. We investigated for all the atypical optic neuritis. So ANA, ENA, RA factor, and serum NMO and MOG were negative. Since the patient had seronegative, suspecting seronegative optic neuritis, so we went ahead for all the infectious and inflammatory causes, which came out to be negative in chest X-ray, the TRI-DOT, ECG, echo, and carotid Doppler. CG MRI brain with orbit showed right eye subtle thinning of the right optic nerve, but there was no post and contrast enhancement, and the other segments of the brain were within normal limits. In the VEP, right eye showed reduced amplitude and prolonged latency, and left eye was within normal limit. In the CSF cytology, there was 100% lymphocytes found. The proteins and sugar were within normal limits. So this gave us a picture of inflammatory CSF cytology. All the infectious etiologies were negative in the CSF. We then went ahead with the GFAP antibody testing, in which the CSF GFAP were negative, but the serum GFAP came out to be positive. Since the GFAP is associated with a lot of neoplastic associations, we went ahead to rule out any malignancy for which we have got done USG abdomen. And there was an incidental finding, left ovary hemorrhagic cyst. She was advised CCT abdomen as well, but there was no evidence of any malignancy. And the gynecology referral was done, for which no immediate intervention were needed. Rest all the parameters were negative. So initially, we treated patient with IV methylprednisolone 1 gram OD. And once the patient was found to be GFAP positive, we shifted to IVIG 2 mg per kg for 5 days, and then switched over to oral prednisolone with slow tapering. So currently, the ocular findings were 636 vision in right eye with the impaired color vision. The pupils were grade 1 RAPD, but disc edema resolved in right eye as in the left eye. This is the OCT RNFL picture, and the macular GCC showed thinning in both the eyes. Thank you.
Thank you. So, what are you trying to kind of highlight by this case? What exactly was your key message with GFAP associated optic neuritis?
So firstly, sir, in the seronegative optic neuritis, we should go ahead with the CSF cytology, and we should keep in mind the differential diagnosis of GFAP-associated optic neuritis. And secondly, if the patient was found to be GFAP positive, since it can be associated with other systemic diseases as well, and the neoplastic association is also there, so we should evaluate for that.
Any outcome differences with the other types of optic neuropathies or neuritis? MS-related, MOG, NMO?
So normally, if we give an initial treatment, so the relapses are relatively little less in GFAP as compared to NMO and MOG.
Okay.
Where did you get GFAP done?
Ma'am, it was done in Lal Path Lab, we advised. So they do...
and what method was it?
So ma'am, it was IHC. They have done... they have got it done from there only.
Right, because normally CSF is more sensitive for GFAP
Yes,
as compared to serum. So it is surprising that you got it positive for serum and not for GFAP. That's first thing. Second thing, when you have GFAP, you have very severe disc edema. So the edema in your case did not appear to be as severe.
Okay.
So that is a concern. And how frequently do you see CRP and ESR so much elevated in cases of GFAP? Is it noted?
No, ma'am, not much.
So why didn't you consider other inflammatory pathology?
Ma'am, we investigated other inflammatory, like we have done the vasculitis profile. We have even ruled out other infectious causes. And after that, when everything was negative, then we went for CSF.
Yeah, but sometimes even you have these biomarkers as negative, these antibodies as negative, they may become positive later. They may be negative at baseline. So I think you may have to reconsider your diagnosis of GFAP over there. It's not so frequently to have this kind of raised CRP and ESR level in the cases of, GFAP optic neuritis.
Okay, ma'am.
Thank you.
Thank you.
Thank you.
We have Dr. Upadhyay, Manish Upadhyay is here. Yeah, you can.
A very good afternoon to everyone. The topic of my presentation is clinical profile and visual outcomes in patients with traumatic optic neuropathy. Coming to introduction, TON is potentially blinding complication of head trauma. Indirect damage to optic nerve is the most common form of TON, occurring in about 1 to 5% of all cases of closed head trauma. Direct optic nerve injuries are rare, and there is no conclusive evidence for standardized treatment protocol for this blinding condition. The aim were to evaluate the clinical presentation and visual outcomes. It was hospital-based cross-sectional study. The sample size was 26 patients, and duration of study was for 6 months. Inclusion criteria were history of impact to head or orbit irrespective of age and gender, and post-trauma reduced visual acuity, and presence of RAPD defect, color vision defect, field defect, and fundus changes. The exclusion criteria were patients with pre-existing ocular abnormalities that might affect the visual function, and patients with other associated ocular injuries that may affect vision or its outcome, and the patient who did not consent for the study. Coming to material methods, visual acuity was recorded using Snellen chart at time of presentation. Intraocular pressure measurement was done wherever possible. Pupil assessment for RAPD was done. Fundus examination was done by indirect ophthalmoscopy, 90D slit lamp biomicroscopy, and OCT. All these tests were repeated after 1 week and 1 month. All these patients underwent CT scan. IV methylpred 1 gram was given, diluted in 100 ml normal saline over 45 minutes for 3 days, followed by oral prednisolone 1 milligram per kg in tapering doses were administered for a period of 2 weeks. Patients were examined every day during hospitalization and later at first week, second week, and after 1 month. 6 patients were managed conservatively due to contraindications for giving steroid like delayed presentation or uncontrolled diabetes. Coming to results and observation, the mean age of presentation was around 40 years. Male predominance, right eye was most commonly involved. RTA was the most common cause, around 83%, and baseline visual acuity around 70% or less than 6/60. Associated injuries which were considered most common, there was periorbital edema and ecchymosis associated, and also subconjunctival hemorrhage, lead lacerations, and some microhyphema. Coming to the orbital wall fractures, most common finding was of lateral wall, zygomatic, followed by medial wall, orbital floor, and orbital roof. In skull fracture, most common finding was of frontal bone, followed by basal skull, parietal bone, and occipital bone. No fracture was seen in 5 patients. With steroid, the baseline visual acuity, the p-value was less than 0.001, which was statistically significant, and without steroid, these were not significant. This is the box and whisker plot showing the treated and untreated group. In treated group, after follow-up, the logMAR value is close to 1, which is a statistically significant improvement. Of 26 patients, 5 patients had presenting vision more than 6/60 and 21 had less than 6/60. 20 out of 26 patients received intravenous and oral steroid. Of them, more than 2-line improvement was seen in 12 patients. 13% and final vision outcome of less than 6/60. Significant difference between baseline visual acuity and post-treatment visual acuity at 1 month review was noted in patients who received steroid. Of the 6 patients managed conservatively, no significant improvement was seen. Coming to discussion, TUN is an ophthalmic emergency. Treatment for this devastating cause of vision loss is not yet standardized. The most common cause of TUN was RTA, and young males were predominant victims. Associated skull orbital eye involvement vary depending on severity. Steroid treatment in TUN has been greatly influenced by National Acute Spinal Cord Injury Study that concluded that megadose steroid used within 8-hour injury showed better neurological outcomes. However, this was in contrast with the crash study. In our study, high-dose regimen similar to optic neuritis treatment trial ONTT was given. 26 patients in my study, 26 patients, 6 patients were untreated, and 20 received corticosteroid. The results of statistically significant visual improvement were 0% in treated group and about 56% treated group. Total number of patients in my study were 26. TUN in the middle age group was more common, which was consistent with study done by Rajnigant et al. And the study conducted by Chow et al. Predominant head trauma origins were attributed to RTA. Studies by Levin et al., Intras et al. Have demonstrated that treating TUN, whether with corticosteroid, extracranial decompression, or combination, yields better improvement in visual acuity compared to the conservative management alone. Coming to conclusion, regimen IV methylprednisolone as proposed by ONTT is safe and effective in managing TUN patient presenting within 3 days of onset of defective vision. With steroid, visual outcome was good as compared to patient managed conservatively. Those with baseline vision less than 6/60 and those managed conservatively did not show statistically significant improvement. Thank you.
Thank you. So just take care of the time as well. Was there a what was the mean duration between the injury to you giving the steroids in these patients, and were they able to actually do a proper assessment of the baseline visual acuity, because a lot of them may have
So mean duration the patient presented were at least for 1 week. If within 1 week they has presented and there was no contraindication, then I have given the steroid.
Because that makes a big difference to outcome, right? And normally
Yes,
you want to give it soon, right away.
Yes.
And also in terms of the the baseline parameters, you were able to assess them adequately with with low vision, below 6 by 6. It's very difficult to assess 2 by 2 meters or 3 meters of what difference happens.
Sir, yes, sir. I was successful to adjust, and I've included those person only, those were in the criteria and those were fit for assessment also, sir.
Okay, so that does rule out some of the severer.
Yes.
Okay.
Did you say IOP wherever possible in your presentation or all cases?
No, sir. Whichever patient measure were RTA cases, so wherever it was possible, IOP was measured. Not all cases, sir.
Okay. Why was it not possible? Some method we can use, isn't it? There are so many methods of assessing. I just wanted to know
Yes,
that.
sir. Some patients are
Okay.
were not cooperative or having severe lead edema, so there was not possible for IOP measure.
Thank you.
Thank you, sir.
Please take care of your timings.
Yeah, Professor.
Good afternoon, everyone. The topic for today's topic of my study is to assess the effect of administration of high dose of IV methylprednisolone in pediatric optic neuritis. So, as we all know, pediatric optic neuritis is a more challenging entity as compared to the adults, given the delayed presentation of the patients. The causes can range from demyelinating causes to para-infectious, infectious and non-infectious causes. So in our study, we have included patients which presented to us with the history of with history corresponding to the optic neuritis, and then we've gone ahead and diagnosed them with optic neuritis, and then followed up with our investigations and clinical assessments to give a definitive diagnosis. The investigations, our ophthalmic examinations was comprised of BCVA, contrast sensitivity, color vision, fundoscopic examination. Investigations comprised of neuro relevant laboratory workup, neuroimaging like MRI brain orbits and spine, and serological tests comprising of MOG antibodies and anti-aquaporin 4 antibodies. The final clinical diagnosis was made on the basis of the presence or absence of RAPD, dyschromatopsia, optic disc edema, visual field defects, and abnormal visual VEPs. We have 6 representative cases. So in the first case that presented to us, we can note that there was a diminution of vision in the left eye with pain on ocular movements. The visual acuity was hand movements with presence of RAPD. Disc photo revealed the hyperemic left disc with subnormal VEP responses. MRI was done for the patient, which showed enhancement of the optic nerve sheath. However, the rest of the brain was normal. Hence, this patient was diagnosed to have isolated pediatric optic neuritis. This was a similar case, but involving both the eyes. The MRI here also gave us optic nerve sheath enhancement, but a normal brain, and hence the same diagnosis was made for this patient as well. In the third case, we had bilateral retrobulbar neuritis, and this patient reported to be MOG and NMO antibody positive with MRI spine was also done for this patient, showing mild prominence in D6 to D8, and a diagnosis of ADEM-like acquired demyelinating syndrome was made. In the fourth case presenting to us, it was a similar case, but also had a history of iron deficiency anemia, and an isolated pediatric ophthalmic optic neuritis was made. The diagnosis was that. In the fifth patient, we had both eyes severe vision loss with multiple T2 hypertense lesions in both thalami. So after 1 month follow-up, after we have administered IVMP, according to the ONTT trial, these were the final visual acuities of the patients. We can see in that the sixth patient, the last patient, did not recover as they did not refuse to enroll in IVMP. So these were the results of my studies. Most patients were male, 17% of them were females. About 80% of the patient presented with bilateral optic neuritis. And in the MRI, in case 3 and case 5, a diagnosis of ADEM-like demyelinating disease was made. According to the ONTT protocol, IVMP and oral prednisolone was started for the patients, and we could see significant visual improvement. The take-home message for this study would be that a high clinical suspicion and a prompt and an apt management is crucial for the favorable visual outcome. It's important that we also include our neurologists and pediatric colleagues for the more comprehensive approach, and we must take into account that IVMP can have some systemic side effects as well. So we have to do all the administration and a close monitoring. Saving a child's sight is not just restoring vision, but giving them a world of limitless possibilities and dreams. Therefore, pediatric optic neuritis demands a more meticulous approach. Thank you.
Thank you. Was there any difference in your management approach in the patients that were NMO-MOG positive as
Yes,
compared
sir.
to the other?
We had also started them on mycophenolate and given some immunomodulators and immunosuppressants.
Immunomodulators are contraindicated in NMO-MOG. Okay, fair enough. So yeah, obviously the management of NMO-MOG is different and requires more aggression. In fact, that's a very, particularly NMO is a poor prognosticating factor for outcomes.
So, since we're dealing with pediatric patients, did you consider malingering as one of the causes in any of the patients? I mean, since
So
many of them...
most patients did show signs of disc edema, so malingering was a little less likely. And we also the imaging studies showed us changes. Therefore,
So the point I'm trying to make is that when the child presents with bilateral severe visual loss and there are no ocular findings, we actually like before rushing to the other things, if we as a protocol also just look for that also. It's a different subset. I'm just
so in a retrobulbar case, due to the paucity of symptoms.
Absolutely.
Yes.
Thank you very much.
Thank you, sir.
Dr. Radhika.
Dr. Radhika, I think you're not a ratified member as yet.
No, I think membership number is not. You can present, but it will not be judged.
Yeah, so we won't be judging you, but it's great that you're taking the effort to come and present, and all the best.
Thank you, sir. Good afternoon, everyone. I'll be presenting on persistent diagnostic challenge, managing an evolving case of optic neuritis. So what do we know already about optic neuritis? We know that it is an inflammatory disorder of the optic nerve presenting with acute vision loss, pain with eye movement, and visual field defects. It is often associated with demyelinating conditions such as multiple sclerosis, but can also occur in autoimmune, infectious, and nutritional disorders. So the diagnosis requires a comprehensive workup, including neuroimaging and laboratory tests to determine the underlying cause and guide for appropriate treatment. The aim of this presentation is to report a fascinating case of unilateral optic neuritis in a young male that continued to pose diagnostic dilemmas, showcasing the complexities in its diagnosis, and to analyze differential diagnosis of optic neuritis, highlighting the need to distinguish between various causes for accurate diagnosis and treatment. So this is a case of an 18-year-old male who presented with sudden onset unilateral diminution of vision in the left eye from past 4 days after waking up in the morning. On systemic history, there was no history of any similar complaints in the past, no history of any systemic illness, no history of any similar complaints in the family. He was vegetarian by diet, takes adequate sleep, and there was no history of any allergies or addictions. On ocular examination, the visual acuity in the left eye was decreased. It was 6/24. Grade 2 RAPD was present, defective color vision and contrast sensitivity. Extraocular movements were full, free, and painless in all directions. The right eye was within normal limits. On dilated fundus examination, right eye, the fundus was normal. In the left eye, blurring of optic disc nasal margins with a hemorrhagic spot near to the disc was present. Macula and rest of the fundus was within normal limit. So we did an automated perimetry. Right eye was within normal limits. In the left eye, there was an inferior altitudinal field defect respecting the horizontal meridian. On further workup, we did a fundus fluorescein angiography, which showed normal dye filling in the initial stages, but in the later stages, it showed disc staining in the left eye with minimal leakage, suggestive with disc edema. We did an MRI brain plus orbit plus 2 mm optic nerve cuts, which showed bulky retrobulbar and intraorbital segment of the left optic nerve with enhancement suggestive of left optic neuritis. The VP was also increased pre-100 latency in the left eye with decreased amplitude. So after doing a multidisciplinary approach, we got a neurology consultation. We did a CSF lumbar puncture to rule out any infective cause, and systemic infectious and autoimmune workup including ANA, ANCA, VDRL was done, but all the tests came out to be negative. Serum anti-MOG and NMO tests were also done, which were also negative. So what did we found? We found the oligoclonal bands were also absent in both serum as well as in CSF. Low serum B12 levels were present. Increased serum immunoglobulin levels were there, but it was non-specific. So based on the above clinical findings, the most probable differentials were, first was multiple sclerosis. If we take respect to the age, unilateral optic neuropathy, and the MRI was consistent with demyelination, but the oligoclonal bands were absent. He was vegetarian and the serum B12 levels were low, so that was consistent with B12 optic neuropathy, but there was spontaneous improvement before supplementation. Third differential was NAION because of the sudden onset unilateral vision loss upon waking, hyperemic disc and altitudinal field defect, but ischemic mechanism was still not clear. On further course, the patient was planned to start IVMP, but on second day of admission, spontaneous improvement in vision was noted with resolution of fundus changes. So the patient was kept on annual follow-up and given injection B12 injections. At 1 month follow-up, the visual acuity was 6/6 parts with mild red desaturation. Discussion: this case of unilateral optic neuritis with acute vision loss, optic disc blurring and inferior altitudinal field defect posed a diagnostic challenge due to overlapping features between atypical and typical optic neuritis. Differentiating demyelinating as well as other causes of optic neuritis is crucial to guide the treatment. This case highlights the complexity of diagnosing optic neuritis and a need for a thorough multidisciplinary approach to understand its diverse etiology, which is crucial to prevent mismanagement and optimizing outcomes. Thank you.
Thank you. Very good presentation, and it's unfortunate that we cannot mark you for it this time. And we hope that, of course, it amplifies the importance of becoming AIOS members early. And we hope that in future you will be here for an award.
Yes, sir.
What was the final diagnosis for this patient?
Sir, we couldn't reach to a definitive diagnosis still, but we are suspecting among these 3 causes only.
Sure, I guess. But you didn't give any treatment.
No, sir.
So
we give
this
B12 injections.
I hope that was not the therapeutic intervention that was there. I mean, I don't think the patient. I mean, did you check for B12 levels prior?
During our workup, we checked the B12 levels. It was low.
Okay, so
yes, sir.
Well, B12 is also known to cause visual dysfunction. But thank you very much.
All the best.
Who would be presenting optic nerve meningioma versus glioma, clinico-radiological diagnosis. Next is Dr. Anu Sherawat. Please be ready with your presentation.
Hi, hello, and a very good afternoon. Optic nerve glioma and optic nerve sheath meningioma. So are these tumors a clinico-radiological diagnosis? If so, why is it still a diagnostic difficulty? Let's find out. Optic nerve gliomas comprise 1% of the intracranial tumors and meningiomas 1% of all the meningiomas. Still, optic nerve glioma is the most common optic nerve tumor and meningioma follows that. It's a diagnostic difficulty because the first reason, rarity of the disease, and the second thing being usually getting misdiagnosed as optic neuritis, thereby leading to all the problems as listed on your screen. So we analyzed retrospectively 36 optic nerve tumors, 15 gliomas, 21 meningiomas for the following. The mean age was 15 years among the glioma patients, with 53% males, and 43 years in the meningioma group, with 57% being females. The main clinical features were mostly common: protrusion of the eye, diminution of vision, strabismus, extraocular movement restriction, disc changes. However, normal disc was seen in 13% of patients, followed by mild pallor, severe disc pallor, hyperemia, optociliary shunts, and choroidal folds. The mean duration of symptoms among the glioma patients was 52 months and 73 months among the optic nerve sheath meningioma patients, and most of them had protrusion of the eye and diminution of vision. The appropriate imaging in optic nerve tumors is MRI brain and orbits, plain and contrast. On your left side, glioma demonstrated by the enlargement of the nerve itself, hypointense on T1. However, a soft tissue mass along the nerve sheath on your right side, hypointense on T1, is suggestive of meningioma. In T2 weighted images, glioma displays high signal intensity and is definitely hyperintense, whereas meningioma can be iso to hypointense. Contrast enhancement seen in both the tumors: gliomas usually irregular and botchy, whereas meningiomas regular, circumferential, with a centrally non-enhancing optic nerve.
Okay, the timer is not there.
The two classic radiological signs in meningioma are the tram-track sign in axial cuts, and in the coronal cuts it's the donut sign. So the patterns are tubular, globular, and fusiform. Fusiform usually gets confused with the glioma. Type 2 being with extension to the optic canal and supraorbital fissure, whereas type 3 being intracranial extension. Treatment strategies among the gliomas: chemotherapy was given in 7%, usually under 3 years age group, whereas 67% radiation. Among the meningioma patients, radiation was given in 95%. Incisional biopsy and debulking required only in few ambiguous cases. So how do we give EBRT? Usually, the T1 weighted axial and coronal images are registered with the planning CT. The gross tumor volume, which is the area of contrast enhancement, the area of tumor, of course. When this is expanded by 1 centimeter in all the directions, we get the planning target volume. Target specific radiation, as on the first image, 95% prescribed dose of radiation goes to the area of interest, followed by 50% to the surrounding area, and then 20% to the further area, thereby preventing collateral damage. So let's have a look at the patients who had excellent response with improvement in their visual acuity and also reduction in the glioma as well as meningioma size following EBRT. So our study stands out from the others in the way that optic nerve glioma and meningiomas were analyzed, however separately. Diminution of vision and proptosis were the main clinical features in both the groups. MRI brain with orbits with contrast enhancement was done in 100% in either group. However, EBRT was the mainstay of treatment, and both the group of patients had excellent, stable or good visual outcome. So yes, both optic nerve gliomas and meningiomas are diagnosed clinico-radiologically, restricting surgical intervention only to cases of disfiguring proptosis and intracranial extension. Early diagnosis with fundus examination, correct requisition of MRI, precision reporting, and earlier access to neuro-ophthalmologists, ocular oncologists, accurate treatment with EBRT, thereby will lead to better visual outcome or stability. Thanks a lot.
So,
in our study, 27% had neurofibromatosis. The rest were not associated. So. Yes, sir, those were analyzed, but due to lack of time, I didn't put it here. Leash nodules were found in almost 50% of whomever had neurofibromatosis changes.
So in fact, that is the question.
Yes, sir.
See, the presentation is sometimes very similar, you know, and the outcomes also, as we've seen, tend to be similar. So what was the need to differentiate between the two? And the need to differentiate is what was just being discussed, that because gliomas will have separate associations that you want to be looking at, definitely.
Yes, sir. So the basis was not to compare either, but the optic nerve tumors usually can be a diagnostic difficulty, you know, mostly getting diagnosed as optic neuritis, thereby leading to various inappropriate investigations and steroid treatment, and then getting referred as an optic nerve tumor. So the idea was not to compare glioma.
If you analyze that as well, no? To see that why does it matter? Why do we need to know?
Okay.
That's also important. Okay.
What was the percentage of opticociliary shunts in meningiomas?
We found almost 15 to 17%.
Out of your 27 patients?
Yes, sir.
Okay, thank you.
So now may I request Dr. Anu Serawat to please come and present her paper, please.
Good morning. Today I'll be discussing an early reliable diagnostic biomarker for non-arthritic anterior ischemic optic neuropathy. NAION is a type of optic neuropathy in which optic nerve head experiences partial or complete infarction due to occlusion of short posterior ciliary arteries. It is the most common acute optic neuropathy in 50-year-old and older population. In one Indian study, it was identified as the second most prevalent etiology of acute optic neuropathies following demyelinating optic neuritis. OCT is a non-invasive imaging technique with high resolution which offers an objective approach for evaluating individual retinal layers. It depicts the most evident finding of axonal loss as thinning of nerve fiber layer in NAION. But retinal nerve fiber thinning can only be detected on OCT subsequent to the resolution of optic disc edema and RNFL thickening, a process that may require up to months according to previous studies. Consequently, RNFL thinning could not be utilized to establish diagnosis in early phase following the onset of symptoms. Around 50% of the retinal ganglion cells are situated in the human macular region, and NAION often impacts the papillomacular bundle. Investigating the macular region using GCIPL could potentially be beneficial in identifying early structural abnormalities. So the aim of our study was to study the ganglion cell layer and inner plexiform layer thickness in patients of NAION. We did a descriptive observational cross-sectional study in our tertiary care hospital in New Delhi with 20 patients, and we involved both the eyes of the patients. Inclusion criteria was patients with unilateral NAION who presented within 15 days of onset of symptoms, and we excluded all the patients who presented after 15 days of onset of symptoms bilateral optic neuropathy or associated giant cell arteritis. Then we went for complete evaluation of each patient, including complete ocular examination, visual acuity, color vision, contrast pupil assessment, and dilated fundus examination. Then we went for visual fields assessment by Humphrey Field Analyzer. We also went for ESR and CRP evaluation to rule out any arthritic cause. Then we went for 3D segmentation to compute GCIPL thickness on STOCT. Our results showed that mean age of the patients who presented to us was 45 years. 60% of them was comprised by males. The average day of presentation we saw was 12 days. There was a significant difference in the visual acuity of the NAION eye and the fellow eye. The mean deviation of visual fields in NAION was minus 12.05 decibels, and in the fellow eye was 0.29 decibels. Then we compared the mean GCIPL thickness of NAION eye and the fellow eye, and it turned out to be having a significant difference with p-value less than 0.001. This is a scatter plot showing association between visual acuity and mean GCIPL thickness in NAION patients. There was a moderate negative correlation between the visual acuity and mean GCIPL, and this correlation was statistically significant. This is a scatter plot depicting association between visual fields and mean GCIPL thickening, and it showed a very strong positive correlation, and this correlation was statistically significant. Our study showed that NIN eye showed a significant reduction in mean GCL IPL thickness compared to the fellow eye within 15 days of disease onset. GCL IPL thinning showed significant correlation with visual acuity reduction and visual field defects. Our study was comparable with Keller et al. And Coppersmith et al. They observed a substantial decrease in GCL IPL thickness in comparison with the fellow eye. Agarwal et al. Revealed that GCC loss maps showed excellent point-to-point correspondence with visual field loss in most of the altitudinal visual field loss cases. Various studies have been conducted to depict GCL IPL thinning in chronic NAION cases, but acute changes in GCL IPL thicknesses have been studied only by Dom Pablo et al., which demonstrated that a substantial reduction in GC IPL minimum was found as early as 2.2 days following the onset of symptoms. Conclusion. So we already know that there are a number of studies which have reported thinning of RNFL and GCL IPL in chronic cases, but we have emphasized on early changes in GCL IPL thickness and its correlation with visual dysfunction. An attempt was made to establish GCL IPL thickness as an early biomarker in NAION. The limitation of our study was that it was a cross-sectional design. A longitudinal study design and a larger sample size can provide additional data in establishing the correlation between the GCL IPL thickness, visual dysfunction, and NAION. Thank you. Yes.
So, if the deficiency in the blood supply pushes the artery does not produce changes in the chloride, but in the epiphyseal chloride which is characterized by the cavernous degeneration of the pupil. So, according to Harry, if the IOP is less, the perfusion pressure is better, so there is better filling.
Yes.
Harry, who has done a lot of
yes, so true, but the study was not related to the perfusion. So yes, of course, Harry's work was landmark both for all aspects of ischemic neuropathy, particularly trying to understand the etiology. Yeah, truly, absolutely, especially using fluorescein angiography to understand the dysperfusion. Yes, I think the major shortcoming of your study is that you're not followed up the patient, because it would be a useful tool to prognosticate, because that is one thing that we still lack to be able to. Yeah, so while it is correlating with poor visual function at the time of presentation, whether it correlates well with the final visual acuity is a more important question to answer rather than just an. But yes, interesting. We hope that you will get a chance to follow up these patients and come out with
I'm following
better.
up those patients.
Great.
Yeah, so that's what we need to probably understand, that like the altitudinal field defects, the ischemia leading to the optic neuropathy, it's not just confined to the NAION only. Now we have a lot of atypical optic neuritis which are presenting almost like that, especially the MOG and all, and the NMO which really leads to a lot of ischemia of the optic nerve. So to really label this as a diagnostic biomarker, I mean, it may not be exclusively confined to NAION only.
Yes.
So essentially it remains a combination of both clinical as well as the the investigative modalities which may help you reach a complete diagnosis.
Yes.
Okay, so that's why we cannot just label it just exclusively and like that.
Sure.
But nice work. Thank you.
Thank you.
Next is Dr. Snehal Nimje. Is she there?
Snehal not there. Okay, I think that completes the presentations.
Dr. Anita and she are there.
Have they come?
They have come, they can present.
Thank you. Thank you very much.
Photograph with all these speakers.
Thank you so much.
Yes.
Thank you so much, and all the very best to all of you.
Great presentations. It was wonderful and very enlightening, and it's very good to know that there is so much vibrant and interest in neuro-ophthalmology. We don't need to add or anything. Na? You're collecting and you'll total up. Great. So thank you. Sure. बड़ी जगह sign कराया तुमने यार. So I think we'll get the speakers here if possible. If they are there, we'll take a photograph. Yes, please. Thank you.